Welcome, curious minds, to another deep dive. Imagine a vital pipeline, the biggest one in your body, quietly under immense pressure, 24/7.
Mm,
It's your aorta, the main highway for blood leaving your heart. And sometimes this crucial vessel, well, it can develop silent weaknesses or sudden, really catastrophic problems.
that's right.
Today, we're embarking on a deep dive into two distinct but, you know, equally critical conditions that can affect this incredible artery. We're talking abdominal aortic aneurysms,
Mm-hmm.
AAAs, that's like a dangerous ballooning,
Mm-hmm.
and aortic dissections, which are more like a sudden, devastating tear.
Yeah.
Our mission here is to strip away some of the medical jargon, give you those aha
Yeah.
moments, and really show you what's happening inside so you can understand why these conditions are such a race against time.
Precisely. We've synthesized insights from, well, quite a stack of medical texts and research. We want to transform that dense information into a clear, compelling picture for you. Our goal is for you to walk away not just with facts, but with real understanding, knowing the fundamental difference between that ballooning
Yeah.
and that tearing, and why that distinction is absolutely vital for, well, saving lives.
Okay, let's start with the silent one then.
Yeah.
The abdominal aortic aneurysm, AAA.
Yeah.
When you hear aneurysm, it just sounds pretty scary. What exactly is in AAA, and why does it pop up in the abdomen so often?
Well, at its heart, and AAA is basically a dangerous bulge in your aorta. Think of it like a weak spot on an old garden hose that starts to swell under pressure.
Okay.
It becomes a true aneurysm when that bulge is more than 1.5 times its normal size, typically over 3 centimeters.
Right.
Now, the reason the abdomen is so common, well, it's often because of the sheer forces, the hemodynamics, as blood passes the renal arteries just below the kidneys. That section of the aorta, the infrarenal part, it just takes a lot of punishment.
Mm.
And the underlying problem here, it isn't just pressure alone. It's a slow, insidious weakening of the aortic wall itself. Proteolytic degeneration, inflammation.
Yeah.
Imagine the strong, elastic fibers that give your aorta its integrity slowly, well, dissolving from the inside. It's almost like the concrete in a sturdy bridge slowly crumbling over time.
Wow.
And that makes it vulnerable to dilation, to ballooning out.
So if the wall is slowly crumbling, who's most at risk for this kind of internal decay? And you mentioned something interesting earlier. Are there factors that actually seem to protect you?
Yeah, that's where it gets really interesting, actually. The absolute #1 modifiable risk factor by a long shot is smoking.
Right. Still smoking.
Still smoking. It's incredibly destructive to blood vessel walls. Other major players include general hardening of the arteries, atherosclerosis, being over 60, male sex, and being of Caucasian descent,
Okay.
and certain genetic conditions that affect connective tissue, like Marfan or Ehlers-Danlos syndromes. They also put people at higher risk, even things like hypertension and historically syphilis.
Syphilis. Yeah.
Yes, though less common now. But what's truly fascinating, and maybe counterintuitive for many, are the protective factors. Female sex, a non-Caucasian background, and even moderate alcohol consumption are noted as protective. But the biggest head-scratcher for many is diabetes mellitus.
Diabetes? That seems odd.
It does, doesn't it? We often associate diabetes with all sorts of cardiovascular issues, but here it actually appears to offer a surprising protective effect against AAAs. It suggests maybe a unique pathway for AAA development, something distinct perhaps from general atherosclerosis. It's quite a complex picture.
Definitely complex.
Yes.
So given it's often silent, not causing symptoms for maybe years,
Yeah.
how does someone even find out they have an AAA? What are the ways it gets discovered?
Yeah, most patients are in fact completely unaware, asymptomatic.
Right.
They might only be found incidentally, meaning doctors just stumble upon it during imaging tests for completely unrelated reasons, a scan for kidney stones or back pain or something else.
Just by chance then?
Often, yes. Or sometimes during a routine physical exam, a clinician might hear a kind of whooshing sound over the abdomen. We call that an abdominal bruit.
Yep.
Or they might feel a pulsating lump in the belly, almost like a separate heartbeat. That's the expanding aorta itself.
Wow.
Now, if it does become symptomatic but hasn't ruptured yet, patients typically describe a deep, nagging pain, usually in the abdomen, the lower back, or the flank area.
Okay.
And again, that whooshing sound or the palpable throbbing mass might be present then too.
And the worst case scenario,
Mhm.
the rupture.
Yes, the most critical, life-threatening scenario is when a symptomatic AAA ruptures. That is an acute medical emergency.
Right.
You'll often see a classic triad of symptoms: sudden, severe pain, abdomen, flank, or back, sometimes diffuse, spreading out. Then a noticeably distended or very tender belly, maybe with that pulsating mass.
Okay.
And third, signs of shock, hemodynamic instability. So very low blood pressure, dizziness, maybe syncope, which is passing out.
That sounds terrifying.
It is. You might even see deep bruising on the lower back or sides, flank ecchymosis, which is a telltale sign of internal bleeding. And rarely, but severely, the aneurysm can erode right into the digestive tract, an aortoenteric fistula that causes life-threatening GI bleeding.
Just horrific. So how do doctors diagnose these, especially when, as you said, it's a race against time? Every second must count.
Absolutely. So in a patient who is symptomatic but stable enough, meaning their blood pressure is holding up for the moment,
Okay.
a CT scan with IV contrast is really the gold standard. It gives doctors a detailed map, it confirms the rupture, shows exactly where it is, how big, and importantly, if a less invasive repair, like an endovascular repair, is possible.
Got it. But what if they're not stable?
Right. If a patient is crashing, showing signs of shock, and you suspect an AAA, you don't waste precious minutes on a full CT.
Makes sense.
A focused bedside ultrasound, often called a fast exam component, is the immediate go-to. It's quick, non-invasive, and can rapidly confirm if there's an aneurysm and often signs of internal bleeding.
So stability is the key deciding factor there.
Absolutely. And if someone has a known AAA and presents with those classic rupture symptoms, they might even go straight to the operating room without any new imaging. For asymptomatic patients where it's found incidentally or during screening, an abdominal ultrasound is the initial, simple test, and it's also what we use for ongoing monitoring.
So once it's diagnosed, how are AAAs managed? Is it always straight to surgery, or is there sometimes a watchful waiting period?
Good question. If it's symptomatic, or critically, if it has ruptured, it's an immediate surgical emergency. No waiting.
Okay.
The two main approaches are an open repair that's major surgery to cut out the weakened section and replace it with a graft or a less invasive endovascular stent graft, an EVAR procedure.
Right, EVAR.
Exactly.
Yeah.
That involves inserting a fabric-covered stent through a small incision, usually in the groin, up into the aorta to reinforce it from the inside.
Less invasive sounds better.
It generally involves a shorter recovery time and is often preferred now for many patients, especially older folks or those with other health issues, because it's less traumatic overall.
Okay.
And alongside surgery, powerful medications, often beta blockers, are used. These help reduce the stress on the aorta, slow down expansion, and lower the risk of rupture.
And for those found incidentally, the asymptomatic ones.
Right. For those, doctors typically monitor them closely with ultrasound. There's a size threshold where the risk of rupture significantly increases.
What size is that?
Generally around 5.5 centimeters for men, maybe 5 Euler centimeters for women, though it can vary. Once it reaches that point, or if it's growing rapidly, proactive surgical repair is usually recommended, even if the patient feels perfectly fine.
So below that size, it's just regular checks.
Yes, below that, it's about regular ultrasound checks maybe every few years for smaller ones, every 6 to 12 months for mid-sized ones, just to watch for any growth.
And what about screening? Should everyone get checked, or is it targeted?
The guidelines are actually very specific here.
Yeah.
The Society for Vascular Surgery recommends a one-time screening using that simple abdominal ultrasound,
Okay.
specifically for men aged 65 to 75 who have ever smoked. Even just one cigarette counts in some definitions.
Well, just men who've smoked in that age range.
That's the current main recommendation, yes. Because smoking is such a dominant risk factor, and men in that age group have a significantly higher incidence. Of course, individual risk factors might prompt screening in others.
Okay, that makes sense. So we've covered the ballooning of an AAA, that slow, often silent weakening.
Yeah.
Now let's shift gears to something, well, equally if not more dramatic. Aortic dissection. The name itself sounds like a tear. What exactly is happening here?
You're absolutely right. It's a sudden catastrophic tear. An aortic dissection isn't just a gradual weakening like an aneurysm. It's when the innermost lining of the aorta, the layer called the intima, actually rips. Yes, rips. This tear allows blood under high pressure to rush between the layers of the aortic wall. It essentially carves out a new false channel, a false lumen, inside the wall itself.
Oh, wow.
This false channel can then compress the true lumen, blocking blood flow, or it can propagate, meaning the tear extends further along the aorta, or it can even rupture outwards.
And what causes that initial rip?
It often happens because the strong, elastic middle layer of the aorta, the media, has undergone some degenerative changes, sometimes called cystic medial necrosis. It becomes kind of weak, maybe a bit mushy.
So the wall itself is compromised.
Exactly. Think of it like a tire wall that's had its internal structure weaken or rot. It just can't withstand the constant high pulsatile pressure and the sheer stress from blood flow anymore. And then suddenly it gives way, it rips.
And where do these devastating tears most commonly happen in the aorta? Is it similar to AAA's?
Mostly different, actually. The most common site, and unfortunately the most dangerous, is in the ascending aorta. That's the part closest to your heart, coming right off the aortic valve. About 2/3 of all dissections happen here, and they carry a very, very high mortality rate if not treated immediately. In fact, most of these intimal tears occur within the first few inches, the first 10 centimeters or so, of the aortic valve.
That close to the heart. Wow.
Yes. The second most common spot is a bit further down in the descending aorta, often just beyond a key structure called the ligamentum arteriosum.
Okay. So what are the major risk factors for this condition? For aortic dissection? Are they the same as for AAA's or different?
There's some overlap, but the biggest, most crucial risk factor for aortic dissection is chronic, uncontrolled high blood pressure, hypertension.
Hypertension again.
Yes, it's the single most important predisposing factor.
Yeah.
Other factors include being over 50, male sex, sometimes trauma to the chest, and importantly, certain genetic conditions that affect connective tissue.
Like Marfan.
Exactly. Marfan syndrome is a classic example. Also, Ehlers-Danlos. In these conditions, the connective tissue is inherently weak, predisposing people to dissections, sometimes even in their 20s or 30s, much younger than usual. Also, things like vasculitis, family history, Turner syndrome, even pregnancy can increase risk.
The pain of a dissection, you hear it described in very specific, almost, well, cinematic ways.
Yeah.
Can you elaborate on what that feels like and where it strikes?
The pain is indeed a hallmark symptom. It's present in about 90% of cases, and it's usually very distinct from other types of chest pain.
How so?
Patients often describe it as excruciating, and critically, it's of sudden onset, reaching its maximal severity instantly, like flipping a switch to maximum pain.
Not gradual.
Not gradual at all. It's often called severe, sharp, ripping, or tearing pain. That's the classic description. And it commonly radiates, meaning it spreads, typically to the back, specifically between the shoulder blades.
Between the shoulder blades. Okay.
Yes. And the location of the pain can actually be a vital clue for doctors. Severe pain in the anterior chest, the front, is more common with dissections involving the ascending aorta, the ones closer to the heart.
Right.
Whereas pain predominantly in the back or abdomen is more typical if the tear is primarily in the descending aorta, further down.
Interesting.
And sometimes the pain can actually migrate. As the dissection propagates, as the tear extends along the aorta, the location of the worst pain can actually move.
Wow. What else might someone experience besides that pain?
Well, accompanying symptoms can be quite varied depending on where the dissection goes and what branches it affects. You might get abdominal pain if blood flow to the gut is compromised. Neurological issues are common too,
Like what?
like sudden weakness or numbness in a limb if the spinal cord arteries are affected, leading to spinal cord ischemia. Or even signs of a stroke if blood flow to the brain is cut off or reduced. People can also experience fainting spells, syncope, or develop sudden signs of heart failure if the aortic valve is damaged.
So it can affect almost anything downstream.
Yeah, precisely. It depends on which branch arteries get occluded by the dissection flap.
Are there any telltale signs that doctors look for during a physical examination that might point specifically to a dissection, beyond just the patient's description of that terrible pain?
Absolutely. Physical exam findings can be crucial. Blood pressure, for instance, can be quite erratic. Some patients will be dangerously hypertensive, especially common with dissections in the descending aorta,
Okay.
while others might be hypotensive, alarmingly low blood pressure, which is often an ominous sign indicating rupture or perhaps bleeding into the space around the heart.
Right.
A really key finding, if present, is a significant difference in blood pressure between the right and left arms, often more than 20 millimilli Hg difference.
Why is that?
Because the dissection flap, that torn inner layer, can partially or completely block the opening to the artery supplying one of the arms, usually the left subclavian artery.
I see.
You might also find pulses that are weak, asymmetric, or completely absent in various locations: arms, legs, neck, or sometimes a wide pulse pressure.
Well,
If the ascending aorta is involved, right near the heart, the tear can distort the aortic valve. This can cause sudden, severe aortic regurgitation, blood leaking backward into the heart. A doctor might hear a new heart murmur, specifically a blowing diastolic decrescendo murmur.
A new murmur.
Exactly. Neurological deficits, as we mentioned, are seen in about 20% of cases, stroke signs, altered consciousness, even acute paraplegia from spinal cord ischemia. And if blood collects around the heart in the pericardial sac, you might hear muffled heart sounds, which suggests cardiac tamponade, a life-threatening emergency where the heart can't fill properly.
This distinction you keep mentioning between ascending and descending involvement, it seems incredibly important. How do doctors formally classify these, and why does it matter so much for treatment?
It is the most critical distinction. It fundamentally dictates the entire management strategy. We use classification systems, the most common ones being DeBakey and Stanford. Stanford is perhaps simpler and more clinically relevant day to day.
Okay, Stanford.
Yes, Stanford type A involves any part of the ascending aorta. It could start there or start further down and extend backwards into it. It also includes dissections involving the aortic arch.
So anything involving the first part.
Exactly. Type A is the more common and generally the much more dangerous type because its proximity to the heart, the coronary arteries, and the risk of rupture into the pericardium. These are almost always surgical emergencies.
Okay. Type A equals surgery.
Generally, yes. Stanford type B involves only the descending aorta, meaning the tear starts distal to or beyond the origin of the left subclavian artery and does not involve the ascending aorta or arch at all.
Just the part going down.
Correct. These type B dissections are often managed medically first with aggressive blood pressure and heart rate control unless there are complications.
What kind of complications?
Things like signs of rupture, persistent pain despite medication, rapid expansion of the aorta, or malperfusion, meaning lack of blood flow to vital organs like the kidneys, gut, or legs. If those complications occur in type B, then surgery or endovascular intervention becomes necessary.
Got it. So, type A surgery, type B medical unless complicated. How is it actually diagnosed? You need to know A versus B fast. What are the best imaging techniques when it's literally a race against the clock?
Right. Speed and accuracy are paramount. Initial steps for someone presenting with that kind of sudden, severe chest pain often include an ECG, mainly to quickly rule out a massive heart attack, although some dissections can cause ECG changes that mimic a heart attack.
Okay.
A chest X-ray is usually done too. It might show a widened mediastinum, that central part of the chest containing the aorta, or an abnormal aortic shape. But, and this is crucial, the chest X-ray can appear completely normal in about 10%, maybe even more, of dissection cases.
So a normal X-ray doesn't mean anything.
It absolutely does not rule out a dissection. You cannot rely on it.
Okay, so what's definitive?
For definitive diagnosis, you need advanced vascular imaging. CT angiography, a CT scan with contrast dye focused on the blood vessels, is usually the first-line imaging test in most emergency departments for patients who are hemodynamically stable.
Why CTA?
It's fast, widely available, and gives excellent detailed pictures of the entire aorta, showing the tear, the false lumen, any branch involvement.
But what if the patient is unstable? Crashing.
Good point. If a patient is unstable, or if there's a very high suspicion of an ascending type A dissection where minutes matter incredibly, or maybe if the patient has kidney problems or a contrast allergy,
Yes.
then a transesophageal echocardiogram, or TE, is often preferred. This is an ultrasound probe placed down the esophagus, giving very clear views of the heart and the ascending aorta right from behind.
Done at the bedside.
It can be done right at the bedside or in the operating room. It can provide a diagnosis literally in minutes and is particularly good at visualizing the intimal flap, the tear itself, and assessing the aortic valve function. Aortography, injecting dye directly, used to be the gold standard but is rarely used now, largely replaced by CT and TPE.
Okay. The management you said is incredibly time sensitive. What are the key approaches once a dissection is confirmed as type A or type B?
It truly is a race against time. Survival drops significantly with each passing hour, especially for type A. So management hinges entirely on the type and any complications.
So for type A?
For type A dissections, those involving the ascending aorta immediate circle repair is almost always the answer. There's really no time to waste.
What does that surgery involve?
The goal is to surgically excise or remove the torn segment of the ascending aorta and replace it with a synthetic graft. Often the aortic valve also needs to be repaired or replaced at the same time if it's been damaged by the dissection. It's complex, high-risk surgery. Endovascular repair is sometimes an option in select type A cases, but open surgery is more common.
And while waiting for surgery?
Crucially, even before surgery, you need aggressive medical management to stabilize things. Lowering blood pressure and heart rate rapidly is key.
Okay, and for type B, the descending ones.
For uncomplicated type B dissections, meaning those in the descending aorta without signs of rupture, malperfusion, or intractable pain, the cornerstone of treatment is aggressive medical management initially.
Not surgery first.
Not usually if it's uncomplicated. The absolute priority is to rapidly lower the blood pressure and the heart rate. This reduces the stress, the shearing forces, on the damaged aortic wall.
How do you do that quickly?
We use fast-acting intravenous medications. The most important class is beta blockers, drugs like esmolol or labetalol. They slow the heart rate and reduce the force of contraction.
Beta blockers first.
Always first, or concurrently with other agents. This is critical because some other blood pressure drugs, vasodilators like sodium nitroprusside or nicardipine, can cause a reflex increase in heart rate if used alone.
Ah, that would be bad.
Exactly. That reflex tachycardia would increase the shearing forces on the aorta, potentially making the dissection worse or causing rupture. So beta blockers, first to control heart rate, then add vasodilators if needed to get the blood pressure down further.
What's the target blood pressure?
The goal is very specific and needs to be achieved rapidly, ideally within about 20 minutes. Physicians aim to bring the systolic blood pressure down quickly to a target range, generally around 100 to 120 mmHg, and keep the heart rate below 60 beats per minute.
That low.
Yes, that level of tight control is critical to reduce the stress on the aorta, prevent the tear from propagating further down the aorta, and lower the risk of outright rupture. It's life-saving.
This has been incredibly informative. It's so clear now that while both AAAs and aortic dissections affect the aorta, this main pipeline, and both can be absolutely life-threatening, they are fundamentally distinct conditions.
Exactly.
One is that slow, often silent ballooning,
The aneurysm.
and the other is that sudden catastrophic tearing.
The dissection. Precisely. Understanding the specific pathology, whether it's that gradual weakening and dilation versus that sudden explosive tear, is just vital. Because while both demand urgent medical attention, the specific interventions, the timing, the medications, the type of surgery, or whether surgery is needed immediately, it all differs significantly based on that fundamental distinction. It really is about knowing which kind of emergency you're dealing with.
We've certainly navigated the complex landscape of these aortic conditions today, from the silently growing AAA to the explosively painful aortic dissection. You listening should now have a much clearer insight into the subtle signs, the critical differences that medical professionals look for, and, well, the incredible speed at which decisions have to be made.
It really highlights how vulnerable even the seemingly strongest, most essential parts of our body can be, and how truly remarkable the body's design is, but also how critical early recognition and intervention are when things go wrong. I hope this deep dive leaves you with perhaps a profound appreciation for the engineering of our circulatory system and how small failures can lead to huge consequences.
Absolutely. So what does this all mean for you? Maybe consider this. If you, or perhaps someone you knew, experienced that sudden, severe, ripping pain, maybe radiating to the back, would you now recognize it as a potential medical emergency of the highest order? And understand why getting rapid medical attention is so incredibly vital for conditions like these. Thinking about that, knowing that, well, it truly could be the difference between life and death.